Good morning and welcome to our monthly live endovascular intervention broadcast from Mount Sinai Hospital here in New York City from the Department of Endovascular Interventions. I'm here, your moderator, Vishal Kapoor. And as you can see, we're joined by our youngest attending right here, Dr. David Song. I'm sure you've seen him as a fellow, but now he's suited up to be a part of our faculty, and we're happy for him to joining us.
Thank you.
And as usual, on the hot seat, we have Dr. Krishnan leading the way with another interesting case, supported as a co-pilot by Dr. Guja, who's right in there, and with the rest of the team. So without further ado, good morning, PK. Good morning, Guja.
Well, thanks again, Vishal. And, again, it's really a pleasure to do I don't know what edition this is of our live case, but quite a few. But we're very excited. We have a very difficult case here to talk about, a lot of challenging questions on wire choice, et cetera, et cetera. So anyway, before that, again, to my right is Dr. Guja, who's the Director of Endovascular Services at Mount Sinai, South Nassau. Behind me, again, as always, is Ray Lascano. I don't think Ray's really missed one of these, so it's incredible to have him. To Dr. Guja's right is Shalini Mani. She's our current endovascular fellow, along with Harsh Doshi. And then we have Alina, and we have Mac, our wonderful two nurses. And then on the outside, we have Damien and Peter, who are incredible. And of course, our AV team, which is always there to support us. So we've got a great case, Vishal. Karthik and I have seen this case, and it's pretty interesting. So we'll get right to it with Shalini to present the case.
Good morning, everyone. Patient is a 64 years old male who presented to us with a history of progressive lifestyle limiting claudication of Rutherford Grade II Category 3. He's been experiencing pain and tightness in his calf on ambulation, which is more worse in the left lower extremity as compared to the right. And he denies any ulcers or wounds at this point. His past medical history is significant for heart failure with reduced ejection fraction, with the latest EF being 45% with a small LV apical clot, and his CAT scan is like a non-obstructive coronary artery disease. And he is also a known case of hypertension, hyperlipidemia, and stage 2 CKD. He's a never smoker, and in terms of medications, he is on Eliquis, aspirin, Cozaar, and high-intensity statin. The initial non-invasive diagnostics is suggestive of an abnormal resting ABI with 0.90 on the right and 0.91 on the left lower extremity. And his lower extremity arterial duplex is suggestive of occlusive left SFA disease with a significant velocity drop and a monophasic pattern in his left anterior tibial artery. Moving to his diagnostic peripheral angiography, his left lower extremity runoff is showing a long distal SFA CTO, which reconstitutes distally at the level of anterior tibials. And as a part of the treatment plan, he has undergone CT angiography. The sagittal and axial planes of the CT angiography are suggestive of mild diffusely diseased aorta with a patent mesenteric renal arteries and a mildly diseased distal aorta with a normal inflow iliac arteries with mildly diseased proximal and mid SFA of the left side. Moving forward to a distal SFA CTO, which reconstitutes at the level of tibial arteries, which showing the collaterals in the CTO segment, and it's mild calcification seen over there in the CT.
Nice. Okay.
You can go to the next one.
Wow.
Yeah.
And plan, we had a multidisciplinary team discussion with our vascular team, and in view of his LV dysfunction, we decided to go with an endovascular intervention and the case approach.
This is a great case. Thanks again, Shalini. So David, Vishal, Karthik, and a team. I mean, he's a claudican. And, when you have a claudication, obviously, in this kind of complex disease, I think surgical revascularization is a reasonable discussion to have with. But again, a lot of surgeons, especially in our hospital, I think rightfully so, don't necessarily want to put their patient at risk with the complications of surgery, although a short venous bypass would have a great patency. So here, the idea here would be, okay, he's not rest pain, he's claudication, complicated anatomy, and I'm going to show this. You can see the runoff here. You have, no inflow disease. You have some disease in the SFA, and then abrupt occlusion of that SFA with a large collateral coming off, forming the posterior tibial, which we'll see here in the next picture. So, let's go to here.
This doesn't work.
Doesn't work. Okay, so Dr. Guja will go forward. And you can see here the distal reconstitution zone, the popliteal occluded. Reason we got the CT was, in these kind of cases when you have no disease anywhere else, you really want to think whether you have a popliteal aneurysm, thrombose, something or another. None of that was there, so the CT was negative. And then we went ahead and took a next picture. You can see here that it reconstituted after the popliteal, after the distal P3 segment, and then the AT starts to come back and the PT is robust. And then the next picture, please. And then you see here you have a good PT in the foot. AT is there. I think it's just underfilled, but you can see the PT is forming most of the foot. Again, he's a claudicant, so what we decided was endo first. We're talking to our vascular team, and they agreed that, hey, whatever it is, I think an endo first might be a good approach in this patient. So having said that, we decided to go ahead and start. And you know what? I think in these kind of cases, if you can go back one, Dr. Guja, I'm curious on your opinion. Go back one more. Mm-hmm. So what we decided to do was just to show that go to the diagnostics, to show that we can actually, probably get bilateral access. The cap is not very favorable. The PT is available, so you have some sort of thing. So what we did was we put an 035 catheter here. And Dr. Guja, using ultrasound, just got ultrasound access. And all we did was put a wire in to the foot and a microdilated catheter. So what I'm going to do is just go down with this catheter without a wire and just kind of engage that cap and see how it goes. And you can see it's starting to go very smoothly. So my worry here is this clot or not clot? And part of the reason is, you can see, and right here we're having a little resistance. So we have an 014 gladius wire. And then I'm going to have Dr. Guja start from below with probably a command wire. Give us a command and a gladius.
This is command.
And that's what we're going to try to meet too. Yep, thank you.
I think it's a very important point that PK and Karthik brought out, especially David agree as well, is the ruling out of popliteal aneurysm. I mean, we've burnt hands. Me and Karthik did one case together, and we bailed ourselves out, which we realized later on, which PK brought up when we discussed in our case reviews. Nice inflow, beautiful, like from CT, from angiography, proximal mid-segment looks nice and good. I would call it almost next to pristine. And suddenly it's just stops 100%. And then there's a reconstitution with good two-vessel runoff, at least going into the peroneal and the PT. So you're right. It's always good to know whether is there a popliteal aneurysm that precipitated everything, because then probably, like PK said, the management would change, because then you would probably be more aggressive.
Look at the wire here, Vishal. We're in a collateral.
Correct.
Right? So that's an interesting, that means your luminal here. The other question is, if it's not an aneurysm, is it a dissection, right? And I think that's part of what we need to think about as well. Is it a dissection or not, right?
But no prior history of any intervention from outside. You know how it is. You get second stuff outside. They tried. There's a dissection. Now you have a thrombus over the dissection. So no prior history of intervention.
Give a picture. So no, nothing. No intervention. Nothing. This guy just presented to us with claudication. So Dr. Guja now has the vessel below. And so now this is where I think we're going to go together, because Ray and I checked, we're on the right track here. The collateral gave us confidence that we're in the true vessel. And now Dr. Guja is going to advance the wire from below, which I think is the right thing to do. There's our dilator. Go ahead, Karthik.
So PK, Vishal, I think, the other side.
Not for a 018 catheter, huh?
The other side is so good, right? The question is, she has LV dysfunction. Did she do a clot?
Correct.
Over time,
get us 2 018 catheters, guys.
Yeah, so I think this is again an important point to state that
PK's catheter went in so easily.
Look where this wire is.
Look, already he's almost entered. I don't think we need to even go from below. You might just enter from above.
Okay, let's see. We'll just go with an 018. I just think it's good to have two accesses, because these kind of cases, guys, just get access down below. Put a little microdilator in, and then I'm going to put an 018 catheter down. Oh, we have one, Dave. You don't need to open another one.
Yeah. So that's why we were discussing, me and David, before the cases. Cases like these where the reconstitution is at the tibial level, we want to preserve the tibial anatomy as much as possible, like PK talked about. I mean, if you start dissecting from top, we can re-enter through multiple ways, techniques, and devices. But in this case, maintaining the natural tibial anatomy, which is the bifurcation right here, is always nice. And that's why PK really would, in this case, did the right thing is by getting another tibial retrograde access, and just to have the microcatheter wire in there, one for directionality, the other is to mark anatomically whether you're off plane, in plane, because you're intraluminal from below. Correct. So that goes as a good marker as well. So I think it's always nice to have an extra access which doesn't bother you. Correct. We are not aggressive enough to put sheath in, which I completely agree with the concept of how it is, just to cause minimal trauma, because we want good outflow at the end of the day, even though, like PK said, it's not an ulcer case, but I think it's great. Yes, PK.
So you know what I want to ask Karthik to do is to actually put a catheter from below, because I don't want to dissect into that PT, because I'd like him to cross from below. This way we're intraluminal, and then we can IVUS, right? If I dissect, Vishal, I may disrupt that AT, which I think will cause a problem, which, I'd like to preserve the trifurcation. Obviously, with the advent, we'll talk about therapy in a second, but there's a lot of options for therapy here. So as Dr. Guja now walks this out, he's going to put a O1A Trailblazer down, and hopefully I'm going to pull my wire back or get my catheter a little bit closer for him to just cross. Once he gets the Trailblazer to the tip of, say, 15 on the glow tape, I think what's going to happen is we can have him inject just to see what the cap looks like. And then if he can cross from the cap into my catheter, we can externalize the wire up on this side, go with an IVUS, and then really kind of understand what the morphology is. Right. So maybe Ray or Shalini's railing, so that's fine.
Karthik, what wire do you have there?
It's a command wire.
It's just a command.
Okay. So, okay.
Do you have a wet one in your hand?
Yeah. Yeah, so I think that's a great point that we were talking about. Just trying to go from below and just trying to reconnect it and then create one complete channel.
So we need to rail. Cannot let the wire advance here, guys, because you don't want to dissect from below. It's the same problem below or above. So I don't care if the wire comes back. That's fine. I don't want it to go forward. So coming back is okay. I don't want it to go forward, and that's the key that for all the people who are assisting these cases. You're as important. See the wire going forward? If that buckles and dissects, it's the worst thing you can do. So, you don't want to do that at this stage. As Dr. Guja takes it up, he's going to go ahead and give a hand injection through the catheter.
Let it go a little bit.
A little bit forward, guys. Let it go a little bit. Fix it.
Yeah, I think it's again an important point to know is like finding those micro channels. So I think starting with a hydrophilic wire is the right technique to do in this case, to see if we can find a micro channel and connect it, thereby causing any minimal trauma to the vessel. Yeah. So probably inject.
So Dr. Guja is going to inject from below. Here's the dye. So I'm just going to do a DSA here. So obviously we have the catheter from above, right? And he's getting a little blood. Make sure not injecting air. There we go. Okay, perfect. So once we're going to inject here. Excellent. All right, so a little DSA. And it's going to tell you what wire to choose. And we could talk about cap morphology and wires. Look at that. It looks very strange, right? So we'll talk a little bit about cap morphology and wires. So maybe somebody can freeze this for me right about there. Yeah. So it looks like it's a bad dissection,
Yep, that's what it looks like.
And the question is, are we in a collateral or are we in the posterior tibial? I'm confused now by this anatomy. So let's pull this back and
get some a little bit different angle as well. Yeah, but I think it still looks good, but you're right.
Yeah, let's just take a look on what vessel we're in, because a lot of times you have to be a little careful.
Pull back a little, proximally is very diseased.
Yeah, let's give a little dye here, just make sure we're not in the collateral.
Lower down a little bit.
I think it's a combination of your thrombotic lesion, which probably could be embolic, but underlying stenosis and disease making it worse and making it 100% in this case. So I think that's what's happening. So you might have to switch your wire strategy, which we'll talk about, like the classification, the CTOP classification of how we define our CTOs and how to work on it. So,
well, CTOP is there and everything. I know a lot of people talk about it, but I'm not really a big fan. It is what it is. Yeah, it looks like we're in the PT.
The TP trunk itself is very
The TP trunk is right there. Karthik is right there. You go. Right there. See how nasty that is?
I think it's
so now we're going to go with the command wire or whatever Dr. Guja wants. Let me give you a roadmap, Karthik, for you. So this way we can do it under roadmap. Ready?
Yeah.
No mueva. Ready? No, from the catheter.
I'm sure Karthik will go with a hydrophilic, but if it doesn't go through, probably change it to a stiffer gram tip wire.
There we go. All right, so guys, the cap is not favorable from below at all. We agree?
Correct.
and it's not favorable from above. So I think this is the right decision we made to go with 2 different wires here. So I'm going to let Dr. Guja, as he's working up, I may pull out my wire because I'm not able to advance my catheter. I can force my wire in, but I don't think it's the right thing to do here.
What wire do you have from top?
I have a Gladius here.
Okay. Yeah.
0-4 Gladius. It's not the Mongo, the regular Gladius. And as Dr. Guja comes up, we'll see how this baby. You might need a wire that's a little piercing. He may.
Correct.
Let's see how it goes.
Heavy tip load wire in this case, like a CTO wire. I mean, I know with hydrophilic you're trying to find those channels, but
it's an 018 we can use an Astardo to see.
Oh, we have the 018 Gladius as well, which is a combination of the two. Yeah, here we go. Nope, it's pointing into that dissection plane here. You got to be careful.
Yeah.
Come back a little bit. Yeah, there you go. I think it is a little dissected in this area. See that?
Yeah, it is.
See, so.
There you go.
There you go. Nice job. So maybe now take your catheter there. Okay,
that's
here I'm coming from above there. Let's leave it there. I want to cross from below. I really do. So let's see whether he's able to pierce that tip. If not, I'll come from above. There you go. Nope. So this is what I would
take your micro catheter all the way.
Yeah,
if you can. I know it's probably resistance. Yeah, I believe you.
Because I think it's a dissection plane. So as PK said.
But it's still going into your true lumen because you can see it's taking an up and over and going into
give us a Confianza type wire here, or give us a Confianza from below.
Yeah.
I think he needs a Confianza. I'm going to park my catheter here and just leave it. I think the way to cross is from above. I'll use a Confianza from above if Dr. Guja is not able to get in from below.
I think we just need a Confianza with a tip on it should give us good good support and everything. But again, a very important point to consider, like PK is talking about, is the cap here. So trying to play from both the ends, trying to define which is like the best of the worst cap situation, and then trying to pierce
Give me a Halliburton from above.
So that way we talked about initially, preserving the anatomy or the bifurcation, as you can see. So you can see distally, there is between the PT and the peroneal, there is a direct connection. So the lesion is just proximal to the bifurcation. So what he's trying to do is trying to preserve it. So we have at least a good vessel, 2 vessel runoff, and if you have to stent across, we know the ostium remains still
also favorably wise, the PT is a much more favorable vessel. It runs into the foot
Right.
So for me, if I come from above and I snowplow into the AT and I'm able to do the AT and then now I lose my PT, now that's a problem. That's another reason to get access from below. One of the things here is you really have to be a little careful and not to dissect from one way or the other because you don't want to close this vessel, So that looks subintimal to me. So maybe you might go with a hydrophilic wire, get up top, and then go from above. There you go. Good job. Can I get a curve maker, right?
So I think people always underestimate the peroneal as well. But
okay, now let me track this up.
The SFA.
There you go.
It gives you the collaterals, the lateral and the medial communicating at the ankle. So
I'm going to push this up. Hold on. I'm just going to get this up for Dr. Guja to this level. And now he's going to pull back that catheter. He's going to, you had a good position there. I'm just going to pull back my catheter here a little bit. All right.
Nice.
And I think here, now that he's through that cap, I'm okay coming from above now. Because now he's through. Now I'm just going to push this down a little bit for him. See, there I am. See, right there. So I'm going to give him a little target to go to.
Yeah, it probably needs a little bit of more bend. I think he lost his bend a little bit, so that's
so he can rebend it. Now I'll make a bend from above and I'll come. Remember, it's all about creating planes, guys. Nobody, people need to understand that. In these CTOs, you want to create these planes, and then you want to go ahead and come. So he's created a plane from below, and I stayed without pushing forward, so I have not extended a dissection plane down. Now I'm going to try to find his plane with my wire, and if I find his plane with my wire, I may just pop into his catheter. Maybe. I'm not certain there. I'm not certain. No, I'm not certain.
No.
But, no. Pull your catheter back a little, Karthik.
Just try it. I think you're looking the right.
No. See? That's what I'm saying. Yeah, it's not a good plane. So let Karthik come now. And if you have to do card or reverse card or something, we'll do it here. But I think here, one way or the other, we're going to be able to find it. You can see the dissection planes from above. Okay. Go.
Yeah, sometimes it's so.
That's it. I like that.
Last step.
I like that.
Is what irritates you. Yeah.
Well, this is a tough one. I mean, there's no question. This is a tough case. There you go.
There you go. That should make it almost.
Keep coming. Yep, that's the plane. There you go. Good. Now you're in. Now stop. Now let me pull back my catheter. Now you can just wire it in. Hold on a second. Okay. Oh, I didn't save it, but that's okay. Keep coming, Karthik. Oh, no. Okay. Now, what I would do if I were you, brother, is bring your catheter.
Yeah, I'm going to bring it up. I feel very
looks
comfortable
like I'm
with
in
this
the wrong plane here.
Yeah, you're in.
And I was going to say, one of you, I mean,
my plane looks very good.
One of us is in the wrong plane.
Yeah.
I like to say Karthik is. so.
Yeah, it's tricky, but yeah, definitely you have to get the catheter in. Or if you can get your catheter from top peak and see if it externalizes that way. Yeah. So Karthik can wire into your...
So we can demonstrate card or reverse card now. I think we're close enough.
Yeah, I think so.
But let's try to get in. Go with a hydrophilic wire now. Give me a command and get Karthik a command.
I don't know. I'm a little bit concerned about Karthik's plane now.
I know. The wire's not
moving.
Me too.
Yeah.
It's not behaving well.
Yeah. It is not behaving.
I feel like the whole TP trunk is dissected. So
it is.
Yeah.
No question.
Yeah. So I think at this time you're right. By the time Karthik tries, I think PK will be probably end up being more favorable because you have your so-called your marker of the wire and the plane direction it has to go through. But you're right. You're running in two parallel planes.
Looks like it. So let's get a 2.0 balloon or a 2.5 balloon, guys, for a cart. We'll have it ready.
So I think just for the audience, just to again re-emphasize the point that having multiple angle visualizations, the feel of the wire obviously makes a difference, and that can actually tell you whether you're exactly in the same plane or not, or where the wire is. So always need to consider this, so that way you can see how the two wires are moving, behaving differently.
Correct. Yeah.
Especially Karthik's wire going in all different planes. So not collaterals, even though it looked as if it's taking a turn, but there was no real collateral.
Give me a roadmap here, please.
Yeah.
I think it's important to really keep it that way. So trying from both ends and trying to connect the wires is the goal I think they're working on.
Okay, there we are. Okay, let's see. Nope, that's not it.
Sometimes when you create a plane with confianza and then use a hydrophilic wire, you might find that plane you want.
Yeah, it's just like you said, it's too close to each other, so you might be able to you have to pierce through the plane either from the top or the bottom, whichever is more favorable for you. So you can actually see PK trying to break through that crap. Through his plane into his plane, I guess that's the right thing to say. So, but the way the wire, you look like it's in the direction of, no, it's just running just parallel to your perineal.
There we go. Now I'm going to pull my wire back, let Karthik try to get in, because I'm just creating planes here. Hold on, Karthik. Let me bring my catheter down a little bit for you. Hold on. Oh, a little staining there, which is a good thing.
Ooh.
Which is always a good thing. Pull back. Pull back your catheter a little bit. Maybe you're directing into... Well, what is that little tag? Oh, that's the... Pull back. Let's go to a different view.
Yeah.
Too small.
I would create a plane from above, balloon from above PK.
Yeah, we could.
You can try. I think PK will.
Yeah, I crossed into the AT.
Crossed into the AT.
Yeah.
See, now we're in the AT from above, which is what we didn't want. But yeah, there's the AT. So let me now go ahead and take this catheter to this level, and let's give a dye. Let's get a little bit of dye shot, guys. Here, ready? Inject. So now maybe Karthik, I can maybe.
No, if we can balloon into the AT,
exactly.
I think we should be okay to get PT back.
Yeah, I think it'll be nice to balloon into the AT because that will change your anatomy of the vessel itself, and then you can wire it down.
Disease,
you know what? You know what, guys? Give me a twin pass catheter here. Let's try that from above. Why don't you come? I
would pull back, PK.
You're gonna come back? Yeah.
No, I would.
Okay, let's leave this here. Let's come with the twin
pass. Yeah, I mean, I agree with Karthik's plan of ballooning the AT ostium. It'll change your morphology, and you can wire it down. Because it's going to break your plans.
Yeah, you're more favorable than me.
Correct.
So you want to balloon the AT ostium?
Yes. I would balloon the whole thing.
Let's just try from below for a second. What wire is this?
Command.
Let's just
so remember, ballooning from top, you can also break out the planes which are coming from the distal pop, and you might just pop into your PT perineal as well. So that will change the whole anatomy.
Okay, bring the catheter down, right? Now pull the wire out of the AT. It's okay, we'll cross.
In this case, if you're already creating inline flow by treating the ostial AT, would you still go after the PT?
Yeah, because PT is your main vessel going down to the foot as of now. So you could technically have a 3-vessel runoff. You can fix the AT as well, but we know the PT perineal is a dominant pre-angiographic. So you want to make sure we have one inline flow to the PT for sure.
Unless you
But
prolapse
the
it
AT,
and then
if you
push
need
it.
to fix it, you can fix it as well. There's no harm.
It's not a
You want a
favorable
3-vessel
plane.
runoff.
Agreed.
I think
With
because
no
it's more
ulcer
like
claudication,
I think
and
your
you have a
dissection
good
plane
PT inflow with just an ostial lesion,
I can
I
pull
would
that
probably
back. Let's
prefer
see.
keep it the same natural anatomy as well.
Got it.
So
That's
yeah.
AT. The problem is I don't want to lose this PT.
You won't lose. I think
No, you're
once you
not gonna
balloon
lose
it,
the
we can
PT.
still get into that plane from below.
Yeah.
Okay.
I
See,
think
this
I
I think is your true PT.
Okay.
Yeah, I will. Yeah, I agree with Karthik 100%. I
Let's
will
make
just
sure I'm in the AT
balloon.
here.
And
No, I'm not in the
collateral.
AT.
You're
I'm
in
in
you
the
are.
collateral.
No, you're in the AT. You're in the AT.
Collateral.
That's AT.
Collateral.
That's fine. All right, let's balloon this then. Let's see whether ballooning will help. I agree with that. So give us a 2-0 balloon.
2.
And then, Karthik, you want to change your wire to a
Yeah, I was
stiffer
gonna
wire?
say. Yeah.
Or you want to leave it with this?
Yeah, I think as soon as you balloon, I think it will fall in.
Okay, let's see.
If you create
Or
a plane, I
Karthik
think
can show using a stiffer end and puncturing into the balloon and wiring up there.
Or, or what we can do is put a balloon from below, which I don't want to do because I don't want to get access, but
No.
put a sheath.
No,
Let's try this. Okay, let's
I
see.
think it will fall in.
I agree. Let's go.
As soon as
You got a
balloon
twin
it,
pass
it's going
dame
to
just
fall
in case? Okay.
I got it.
Fluoro, Karthik.
But Karthik, what's going to happen? I think what you should do is still, while he balloons, since you'll get a plane, you can try to see if you can puncture to the plane. So I would still try from below, maybe a
Not
different
yet.
wire. And after ballooning,
What's the
it
wire?
might be more favorable for you. Or what's your wire? Yeah, it's coming back. Yeah, it'll still become more favorable from below as well. So
1 second. Put something over it.
Let's put the wire in the true AT in a second.
yeah.
We were in it before.
Yeah, it was.
There you go. Good. Oh,
Yeah,
you were there. That's it, though.
Yeah, that was the yeah.
There it goes. The true AT. Yeah, good.
Yeah.
So let me now come down. Yeah, let's give us you know what? I'm going to pull it back proximal fluoro.
Yeah, so you balloon all the way to the
Yeah,
distal
no, I
palm.
just want to do the cap.
Yeah,
All right, ready? DSA?
Go for it.
Oh, you can do regular coronary.
Regular coronary.
Okay. Inject. Oh, it's okay.
So I think the idea, like for the audience, is just to create a little bit more lumen. Just tear through your subintimal plane. Try to make it a little bit more favorable for the wires to re-enter either from below or from the top. And then we're right in the true lumen anyway, so we know proximally we should be good.
Let's go up there. Just go up there for now.
So it's like changing a bifurcation as you do in coronaries. When you do a pot, which is proximal dilatation hard enough, it actually makes more favorable to enter. So we're using this as the main branch.
Modify
and trying
the
to modify.
Okay,
Exactly.
That's a good spot.
Make it more favorable.
So what do you have, a 2-0 balloon, if I'm not?
Done. Yeah, just a 2-0. Just going to go
Okay.
up here. I don't want to...
I will balloon the whole, even though it's 2-0, I'll just balloon a little bit more proximal into the distal as well, just to create a channel, break through it.
Yeah, we're there, though, clearly.
Yeah.
12. Okay, down. Okay, now come from below. There you go. There you go. That's it. I'm just going to take my catheter down. And I'm going to... Okay. I'm going to pull my wire out. You want to pull the wire out?
I would not pull your wire out.
Okay, take your catheter in. Let's see now. Yeah, let's see if I can come from above and drop it in. Okay, good. Now let me see if you want me to come from above.
Yeah, try it.
Okay. Oh, almost. Almost. Go to a different view.
Yeah.
Okay. Or we could just maybe micro snare it or something. Nope. Okay.
I don't know if you're in the same plane.
No, I think, Karthik, you were favorable before.
I just like
I don't think we're in the same plane.
Yeah, Karthik, you still have to try from below. The thing is now I would try from below.
All right, let me come from below. Let me try. Give me a confianza here, guys. Hold on, let me
try from below, Karthik.
Yeah, keep going up. Keep going up, brother. You're going to get in. Dissected. That's fine. Come. There you go. Now we're going to meet right there. There we go. Now we're meeting. All right, give me an 035 catheter from above. There you go, right there. Maybe we do a balloon here. Let's go up here. Come here. Go up here with the 2-0. Go up.
Yeah. 10, 12. Down. Good. Now try coming. Whoops.
You pulled it back, but that's okay. Go. Mm-hmm. Nah, you're not in the right plane.
We're not in the right.
Yeah,
Okay.
I think PK has to try. Here.
Okay, let me try. Give me now a confianza, guys. Oops. Can you show me above, bro? Show me above, bro. Oh, my wire came all the way back. That's okay. Do it once, you can do it again.
This is a good plane you have, PK.
See, that goes right into the AT,
yeah,
see?
It's a good plane you have.
Yeah, that's what I'm saying.
But the question is, maybe now we do it with a twin pass. Look, give me a twin pass now. Let me try side wiring it. Here, Karthik, stay there. Let me just try with a twin pass. Walk this out. Walk this out for me. I'm surprised we can't get in. The only other thing we may be able to do is a facilitated reentry with an outback. We have the B-back, right? We can try the B-back. Let's see.
What's your AT wire?
Yeah.
Mm-hmm, we got it here.
Yeah, again, it's very interesting that we are so close next to each other, but the multiple
because we're
planes,
in two different planes.
Yeah,
that's why
the multiple planes is what's causing the issue right here. So
now give me
sometimes you can just
wire.
fly through, but sometimes you have to work a little bit harder. I think that's what's one of the cases right here.
For re-entry devices, would you be concerned about this being too distal or near the claudication?
Exactly. I mean, I guess the bulkiness. I mean, that's why he's talking about the B-back and not the outback. Outback is a little bit bulkier device. So getting in there and going it just becomes tougher. So that's why a smaller caliber re-entry device is probably better, especially as the vessel tapers right here.
Yeah. Well, so now we're going to or something. Yeah, now I'm going to come with an Ashtato through the twin pass.
Correct.
So give me an Ashtato here, guys. Sometimes having two lumens will help you with this catheter, just to drop it in. There's my twin pass catheter. So I'm going to leave it there.
Yeah, it's another very interesting technique that PK is talking about, using the second lumen and try to cross over onto the other side. Oof.
Nothing is working here. I'll leave it there for now.
Yeah.
All right. Okay, maybe that's a little better here. There you go. That's better. Hold on.
Better.
That's a lot. Stay there.
I like that.
Now let me walk this back. Hold on. Let me walk this back and pull this cat wire out. Okay, go now. Try to get in.
1 second. I like that path.
Yeah, that's a great.
I think you have to get your micro catheter in.
Yep, okay, rail your catheter, please. Rail your wire.
Yeah.
So I'm just gonna go in. There you go. There you go. It went in. Do it once, you can do it again, Karthik. Don't worry. Yeah. Almost. Look at that.
Same thing with the filters. You can do it once.
There you go. See, I told you. All right, good. Save that.
Nice.
Save that. Now hold on. Let me just push this down, and then we can just exchange it out. Ready, Karthik? Flora, walk this out.
I'll walk this out.
Yeah, and then we'll just
push your catheter down.
Yep, I'm going to push the catheter. Here, walk.
I'll keep pushing this
down. Walk. Again, out. Now walk your wire out now. Now you can pull out your wire.
Push your catheter down a little bit.
No, the catheter's down, bro.
It's right there. It's in the middle.
Pull out your wire, and then I'll just put another wire from above down.
I'm going to pull out the whole thing.
Pull out your wire. No. You want to give through and through wire. So pull out your wire, right? Now give me a
wire from the top.
Run through. Now I'm just going to wire from top, and then we're going to have through and through wire, and then we'll do IVUS.
Yeah. So again, a great demonstration of just trying to connect the two dots from top and bottom, creating multiple planes.
And also, it's a good demonstration of using coronary equipment, for the vascular people out there. So you see how the twin pass worked. We're able to put a twin pass down. We're able to get two lumens, poke, and then we're able to do it. So I think.
Why don't you just wire the PT?
No, but we'll have through and through though. We'll have through and through. Because now what I'm going to do is I'm going to use this to wire. Yeah, I'm going to use this to wire the. I'll show you what I'm going to do. Watch. What I'm going to do is.
No, what I'm saying is you can have your native vessel, no?
No, but yeah, I'm going to preserve both. Okay. See, what I'm going to do is I'm going to preserve the bifurcation by wiring the AT with the other wire.
Yeah, he wants to do a bifurcation.
Yeah, now you can do a bifurcation preservation. So what I'm going to do is go this way. So I'm going to put this into this and let Karthik clamp it. And then I'm going to come from above and wire the AT, which I hopefully will be able to do. Oops. There you go. Oop, missed it.
Oh, thank you.
There you go. Nope. Go to another view here, guys. The problem is if you have a little bit of a tighter, it's more of a healthier vessel.
Push it up a little bit.
Pull your catheter back, Karthik. Then that's the only way. The lumen size decreases.
The lumen size is bigger in the when you go down, Vishal.
There you go.
Okay,
there
good.
You go.
Okay, now I'm going to walk it out, and Karthik is just going to externalize it and put a clamp on it.
I got it.
Okay, good. So now what I'm going to do is walk this back, and I'm going to wire the AT. Flora for me. So we have a clamp on the PT wire, so we have through and through access. Flora. Now I'm going to, walk this up here, and then.
So you still have the twin pass down?
Yeah, and now I'm going to go with the other wire. Flora.
1 second.
See? I'm going to try to get into the AT now, which I hope I can do.
Yeah, right.
There. Let me just bring this down a little bit. Give me a little dive from above, guys.
Yeah.
Give me a torque array on this thing. There.
A little bit above.
You're right, a little bit higher. Maybe not going to work, huh? Let's see.
It'll work.
Let's try.
Because if we had both, it'd be wonderful. Then it would really be a nice demonstration. Let's do a roadmap here to give me an idea where it is. Let's go, Flora.
And then you go back to your original angle, yeah.
Yep. Okay, good. It's way down. Okay, good. Let me see.
Yeah, you have it open.
It's open. You just got to find the plane now. Nope, that's not it.
I have to come down a little bit more.
With the twin pass?
Yeah, you got it. You got it.
I don't know if that's it.
That's it.
So now we got both. We got the twin pass below, and we got, off-road map. Save that. Flora save, and then off-road map. Okay, let me push this down into the AT. Hold on, Flora. Make sure it's in the AT. Okay, good. Now I'm going to walk the twin pass out. So Karthik is going to walk it out. I'm going to hold this wire. That's why you're using 300 wires, right? So now we need two coronary balloons. Yeah.
3 each, at least.
Oops, stop now. Now I have to walk it out this way. You would just have to advance the wire, Karthik. Oh, you have it anyway.
Yeah, we have it, right? It's clamped, no?
Yeah.
Don't have to worry about it.
Yep. There you go.
Now that we have more technologies than just PTA below the knee, what do you think about bilateral osteo sprees here, or what would your destination therapy be?
I think, where is it? Is it out?
I got it.
Oh, you got it. I think what we're going to do is, we're not going to use a spree in bilaterally. I'm going to balloon angioplasty the AT and a spree across into the posterior tibial. I don't think the data is available for bilateral spree in this particular case. Now, to me, I think preserving the bifurcation is very important. So currently at this stage, what I'm first going to do
You think a spree is better than having a DES?
Well, I think the data with the spree is phenomenal. So I think we'll go with 2 3-0s here. And then we'll just spree into the proximal.
Okay. Well, the idea like PK is talking about, I think is just we don't have much data on the mini crush. If you want to really preserve the bifurcation, we have to talk like in coronary terms, where he's probably trying to do a bifurcation stenting. And nobody knows on Esprit if you can do a mini crush, recross, and do it. So I think that's why he wants to preserve the anatomy, which I think the goal here is.
Want to use AT
so probably might end up using DES, and then distally, if there's a lesion, you can use an Esprit solely for the vessel, and rather than going into the bifurcation.
No, but this is the run-through. Run-through is in the PT.
I think
this is the run-through, right? Yeah.
I'll highly doubt if we keep it provisional in this case, so to say, where we stand.
This is the run-through, right, guys? Yeah.
From the
we'll find out.
into the PT and keep just the balloon angioplasty to the AT, because the AT was occluded proximally
pull
and
your
the
wire,
PT
we'll
as
find
well.
out.
So after so much hard work, and with this present technology, like you talked about, Esprit, and also good data on DES just on the proximal segment.
I think so. We'll see.
I think we have multiple modalities available, which we could do a combination of and still get excellent results.
That's why I think this is 80.
Okay, let's see.
There's too much wire there, right?
All right. Well, we're going to IVUS both. We're going to go into the AT and the PT. So this is likely the AT. We've got our wires crossed here. We'll find out. So we got a 7 front sheet. So now we're going into the AT. More importantly, I really want to know how the IVUS looks to give us an idea No, it's the AT. Okay, ready? Start recording.
Oh, can we see the? Yeah, perfect. Oh,
Start recording.
Are they recording?
Okay, now I'm pulling back. This is the
Significant
AT.
calcification. Yeah.
There's a lot of plaque. Oh my God, a lot of plaque.
What was 100? You can see the other wire right there. Yeah.
Yeah. So.
Atherectomize this.
I mean, the question is whether we.
But you have to take the wire out for atherectomy.
Yeah, I think we balloon angioplasty first. But again, it looks like we're interluminal, huh?
Yeah.
I can't quite see. Most of the vessel looks pretty good.
I think because of the plaque amount.
Yeah.
But you're interluminal most.
Looks pretty good. I'm pretty happy with this.
Yeah, we entered intraluminal
there we go.
into
Okay. All right. So give us 2 3-0 balloons now.
Yeah, I think, Karthik, the problem here is if you do atherectomy, then you have to take one of the wires out, which becomes an issue.
Yep,
then you don't want to struggle
you can always rewire into the AT.
So I'm going to put one wire into the one balloon. You load the other one?
Yeah. I think you can always rewire the AT.
Oh, we got 20 minutes. Okay. So again, Ray, wire. So what we're going to do is we're going to go ahead. I'm going to put this in the AT, and then Karthik's going to load the other one into the PT, and we're going to do a kissing balloon. And then we're going to balloon all the way up top with these 2 balloons. So 2 3-0s is probably like a 4 or 5 lumen, whatever, and we'll take a look. Flora?
Yeah.
Okay, this is going into the AT.
I got this.
So now he's measuring the. So the distal pop is 4.5, if I'm not wrong.
Okay.
This is calcification proximally.
And then the other balloon?
So PK, one point to talk about on IVUS, we don't, or personally, I don't see any real significant thrombus that we were talking about.
Exactly.
Yeah, exactly.
No,
so I'm not too worried. That's a
So
good
I think
point.
that's another important point. Even though the wire flew through, and with the history of LV thrombus and sudden cutoff and all those rule out popliteal aneurysm, we were still skeptical if we missed anything. But on the IVUS, again, there is no real demonstration of thrombus. Something to consider. Because if it was thrombus, then I would have been more aggressive trying to see if I have to put a filter down one vessel or the other to preserve what I started with.
I was actually more excited to see the IVUS findings for the SFA, anticipating that. And we didn't see it.
Yeah, exactly. So that I think that's one important thing here, especially in this
you
case.
have the wire clamped.
Not only focusing on the intraluminal, which we know we can not care much
right,
about, but I think the thrombus morphology was an important determinant in our definitive therapy and strategy. So there was thrombus, then we had to do thrombectomy first and then work on it. If not, we at least skip that step. So I think that's good.
We did bring up the point of the importance of saying intraluminal in the tibials, but with the presence of the
now let's go with the other. Let's go with
that's even,
try to go with the other balloon again.
Is that something still that you're considering?
I think that's a very good point. That's something to look into.
No, I don't think so. It's just not entering the sheet.
Between intraluminal versus luminal re-entry and using a S3 patency.
Yeah.
We know from data on SFA and POP it doesn't matter, but I think it's a very important topic.
Pull the wire real hard.
I don't. We have to ask Abbott.
Yeah, I know, but it should go.
That's going to be our next project to work on it. But all right. So now we're ballooning we did the AT we saw.
Yeah, now
so the idea is to do PT.
Okay, now we're gonna do a kiss now, Flora. Let's see. So we have one balloon there. Now the second balloon is gonna come. A lot of resistance. Show me above.
I think probably from the bed.
No, it's stuck right here. There it goes. Okay, good. Okay, I can't see it, guys. Get this silly thing off. Where's there's one balloon. Yeah, the shutter's there, and then here's the other balloon. Now let's get this balloon further down. Hold on.
The one on
the wires are not wrapped.
They're not wrapped.
Yeah, it's just the pushability.
Okay, go up together, guys.
I will put the PT balloon down.
I'm trying.
Yeah.
Nope, it's not going.
I think what you do is pull your AT balloon back, push the PT, and then you can re-enter with your AT.
That's what I'm going to do here.
So I think, once PK and Karthik are done with this case, there's a lot of interesting points for a definitive therapy. We have a distal popliteal lesion, and then we have a bifurcation lesion with a tapering vessel.
Yes.
We have multiple choices available for the POP, whether it be DCB, whether it be Supera, combination of both. Then for the tibials, we have the DES, we have the Esprit. So mix and match and how to deal with it, I think is the basic determinant. Of course, techniques of crossing very important in this case. Hopefully we got a good demonstration of how we cross. But I think that final destination therapy is also a big determinant in this case.
Go up here.
If you were to, like in this case, I would probably think about stenting the
Down.
popliteal.
Yeah.
How would you overlay that with the spree that you want to place in the osteal PT?
Down.
There's a big size mismatch there.
I know. See, that's the biggest problem we have, is
Down.
to do it the other way. So usually,
Go up here.
again, I have my own thought process
Down.
on it, but here what you do is
Go
try
up
to
here.
put in the biggest supera. I would probably put supera first as possible,
Down.
and then put my distal stents through it.
Got it.
Because what happens if you sew the distal step and you overlap, there is a funneling effect, and then everything tapers down. The supera is really crunched in.
Got it.
So that's a
Right,
strategy to
okay.
talk about. So let's see how it looks. So we did the kissing
While
balloon.
here
We
is,
balloon
this is
inflated.
clamped, so at least you'll.
Yeah.
Hold on, now let me walk both together. Ray, fix the sheet. Wow.
Oh,
It's okay.
You got a little bit of.
they cross each other, no? That's
And
why
the
it's so
balloon-
much difficulty, PK. I got it.
Yeah, I
got
think
it.
so. There was a little bit of wire overlap, I guess. That was caused you trouble.
It's okay. We lose the wire. We lose the wire.
No, we won't lose a wire. Got both of them out.
Yeah, it's just the stickiness of the wire.
No, they both crossed each other.
Yeah.
Okay, good. All right, let's do a DSA. DSA, guys.
Just check.
Inject.
All right.
Well, it's hopefully not anything bad. Cine, DSA. All right.
Very nice.
Okay.
Very nice. You
Beautiful.
just have to balloon that PT segment.
Yeah.
Okay. All right. So give
Very
us
nice.
now. Give us an esprit to the PT. Give me a 3.0 long 014 balloon.
So PK, before we start, you start
40 014.
before you start calling
Take
for
a
balloons,
longer.
can you
3080.
discuss
Give it 3080.
See above.
your
Flora?
algorithm
Flora?
for treatment strategy in this case? So distal pop lesion,
DSA
4-5 vessel.
Brother, 1 second.
DSA?
Flora.
I'll
tell you
let him
right-
take pictures first.
Yeah, I think PK is concerned about how the
How the
two
proximal
balloons-
looks.
Two balloons behaved.
Yeah, Flora above.
Don't worry, behave well.
Okay, DSA.
They'll listen to him, so it's good.
Okay, good. All right, so we got a nice result here. Okay, good. So let's give me a 3040 balloon in the PT I need to go. Let's decide which wire is which is
Yeah,
separate.
I know. The Gladius wire is
So
great.
PK, me and Dave were discussing our strategy for
Oh.
destination definitive therapy.
You took both. Give me one.
Sorry. Well, I think here the idea is going to be to do first. I'm going to preserve my PT. So what we're doing now is what was my anterior tibial dimension? So I'm going to put a 375 in the AT after seeing how the balloon behaves in the PT. So I want the balloon to go to the PT now, which is the PT wire. This is the PT wire?
Yeah.
Okay. So we're going to go to the PT with this balloon. I need a 375 esprit.
So the question is still, so you're going to stent your PT all the way to the ostium, correct?
Right. I'm gonna stent the PT into the ostium. Then I'm gonna do a DCB of the that's what I'm open for discussion. This is my plan. I don't know
Right.
what you guys think, but Flora, for me, let's do the PT.
I would DCB and leave it.
So yeah, so the question really
I'm sorry?
arises is, are we?
Okay. So we got a 3.5 balloon into the PT now. Let's go up. Is it 3.5 red game or 3.0? Okay, we need a 3.5 next. Go up.
So the question, Karthik, for you and PK both is: are you planning to do a stenting of your popliteal, like primary
I don't
stenting
think
with
neither
DCB?
PK or me have a plan of stenting the popliteal. So it looks pretty neat and clean. I think
Walk it back, let's take
DCB
a
just
shot.
with the esprit of that PT would be good. I think.
And what about the AT,
DSA?
which was a CTO?
Well,
Leave the AT the way it is.
there's no flow in our PT.
No, I think it's just that's a dissection plane we thought, right?
No, we got to stent that. You're saying.
Yeah. So we have to
Are you
go in
sure?
a little bit. Yeah, positive PK.
I'm a little worried. Are we in a dissection plane?
No. We are not.
you're fine.
We are not.
Remember,
Yeah.
we haven't
Just
yet
go,
IVUS
go.
PT as well.
Remember
but-
that whole PT is disease.
Let's IVUS the PT.
Yeah,
Walk it
Just
out.
Yeah.
go. I
Let's
would
IVUS
have
the
to
PT.
I would balloon it first before you balloon.
The IVUS might not even, yeah, just balloon it and then you should be able to IVUS.
That's good.
Uh-huh.
That's good.
It doesn't matter. Okay, down. Yeah, I'll just pull that back. I'll just put it.
It could be spasm also, right? You just have to pull back a little bit. I'll go light in the PT.
Yeah,
Pull back the PT balloon. Yeah. That's good. That's good.
You done?
Right there, yeah.
Okay, good.
I think that's why you were a little bit of subinterval, and that's why you see a little bit of decreased flow like you were concerned about, I
All
think.
right, IVUS.
So we're probably in and out. So
IVUS
let's
to
see
the
what the
PT
IVUS
now.
shows.
So it's we're going to do an Esprit in the PT, so we're going to IVUS to PT now. Let's take a picture to see how the flow is. A little higher. Good. Inject. We're going to see how the flow is now.
It's going to be good.
Again,
It's going to be good. It's
looks
good.
a little bit like poo-poo there. But we'll take a better
We
look.
had an access, spasm, everything.
Well, remember the problem, guys, is you don't want to put this Esprit without good flow. So you got to be really careful with that. You really want to have good flow in the vessel when you put an Esprit. So that's what I'm trying to demonstrate, and I think that's important for all of us to remember that. So anyway, we're going to go into the distal PT. We're going to get a measurement. We want to do a reference vessel diameter. Okay, ready? Record. So this is the PT. Coming with the PT. Very small vessel, looks like.
Yeah. Surprisingly, yeah.
Very small
starts
vessel.
to become bigger, yeah.
Right. Mark that. Measure that for me. Okay, and then we'll come back. It looks very good result. No problems. Fluorocardic.
Yeah, that's the only part. That's where you're.
Okay, good.
Yeah.
And so it's a long 375 I want.
Yeah.
375 38 Esprit. Give me a 35 and a 375 long Esprit.
Right to the level of the ostium.
Yep.
Of the trifurcation.
So we're going to do 2 Esprits here.
Second Esprit.
What's the popliteal length? Is it a 6 or a 5? 3.5.
No.
Yeah. The pop is also not that big. Distal pop is 4.5.
So give me a 4.0 DCB and then a 6.0 DCB. The distal SFA is a 6, right? Distal SFA is a 6 or the P1 segment?
Huh?
Give me the Esprit, please.
Yeah.
Right. Time. Let's go.
PK, you want to put 4.0 in the popliteal?
No, I don't want to put a DCB.
DCB?
Yeah, unless you want, because we have 375, right?
Put larger 5.
No, because then it'll be. We'll see what the mismatch is. I agree, large is always better, but I'm saying that we need to figure this out. Prepare 375, please.
One should be enough, no?
Well, I'm going to do 2.
No, we need 2.
Actually, wait, hold on. Let's see. Do a roadmap here.
Ray, hold this wire.
Ray, hold the wire. We'll do a roadmap.
So now you have a 3.538 Esprit in your hand?
Yeah, we need 2, brother. We got to come across that lesion, right? See, there's no flow. We need 2. Just leave this for me.
I think, yeah, right. The flow disruption is at where the real
exactly.
CTO was. So, yeah.
So I'm going to start a little lower here.
This is 375 PK.
3.5. This is 375?
Yeah.
Why'd you guys give me the 375 first? Okay, it's fine. Let's go up here.
It's fine. Just give me a
Go up here. This is 375. We're going to do it in the ostium.
Yeah.
Actually,
That's
should I come across? No, we'll leave it right here.
No, I would leave it.
I'll leave it right here.
It's a 5.0 vessel. I would use a 5.0 DCB.
Yeah.
Okay, remember, how do you go up with this, guys?
Every 5 seconds, 2 atmospheres.
So 2 atmospheres. Let's Flora. Flora now. 1, 2, 3. So.
Yeah, Karthik knows how to count. 1, 2, 3, 4, 5. And then 30 seconds total.
I'm good in math. I still teach math to my son. So
let me call him.
I like the way Karthik says he does everything here. But at home, we don't know.
Yeah,
we have to confirm.
If you call my son, he's going to say, I don't know why I'm getting B+ in math. That's because Dad is teaching.
Daddy's teaching me.
There is a that's what they say. There is a fine line. There is a fine line between a D and a B.
12.
Yeah.
He didn't get it.
12.
Anyway,
let me see the inflation.
I think you're right. PK is right. We'll probably need one more distal stent to really cover that lesion / the subintimal plane we were with the wire initially when Karthik was trying to wire.
Okay, go up high pressure now. I'm not happy with this little non-expanded side. That's better. There you go. That's better. See, that's better. Okay, good. 120? No, 480 is fine.
Yeah, take a short 4.0 and then you can do a bigger
6.0. I would go with 6.0 150.
Yeah, but first a 4.080 and then a long 6.0.
Okay, now give me now. Can you mag up and put it on coronary so the folks at home can see the scaffold?
You know, we positioned the Esprit here perfectly in the osteal PT, but for some reason, let's say if the Esprit were to come back, since it's a scaffold, not really a stent, is it easier to wire? Yeah, exactly. Is that something that we know, or we don't really have?
We really don't know, David.
We don't know. It's hard. That's the reason when we were talking about if he had to do a true mini crush or a crush technique to preserve the AT and the PT, then he'll probably go for a DES proximally because the data is still good on DES, and then distally you can line it with your Esprit to keep the scaffold up there. So I think that's what he's trying to do.
Go up. So you see how we lined up the markers, the night null markers. So this way the markers are well lined up, and now we can go overlapping Esprits. Go up.
So now this is a 3538.
Yes.
Beautiful. Yeah, I think that's where the problem was. Yeah, that's your true problem.
Yep.
Good.
All right. So we're just going to leave it up for 30 seconds now.
Perfect.
We're going to go on both wires for the 480. Okay. Down. Okay, 30 seconds. Go up again. To 12.
Or pull back a little.
No, go up again, just to make sure it abuts. Good, 12. Down. Let's come back. All right.
Nice. So do an overlap.
14. Down. Good. Down.
I think having this technology especially has really opened our hands a lot about trying to preserve the anatomy, the long-term patency and everything as well. So it's a great armamentarium into the below-the-knee intervention, which has actually changed the whole dynamics of the field itself. So, all right, the meat is in the picture.
There you go.
Beautiful. Beautiful.
Oh, the ostium looks bad.
Well, now I'm like, the peroneal.
It looks okay.
AT ostium.
Yeah, I mean, it's fine, no? I mean, it's a CTO.
All right. So, well, maybe we'll balloon it. So first, give us the...
you can cut it. Yeah.
No, I'm not going to do anything right now. Give me the 4.0 DCB. So we're going to put the 4.0 DCB in both the wires now. So it's very important, obviously. You want to get that whole thing. So, kissing Esprits has not been done. So we're going to put both wires in. And, so we're not going to do kissing Esprits here. It's an 018 balloon?
Yeah, you can do two wires.
That's okay. You can leave it to the distro.
Then put it on the AT wire.
You won't put it on the AT wire?
Yeah, because we're going to stop it below the Esprit, right? Don't you think? Or you want to put it on the PT wire?
No, PT wire.
I would put it on the PT wire.
Because it's going to change your anatomy and morphology. Yeah, you don't want to compress on the PT vessel.
See, the problem now is I can't kiss that ostium because of unless we do two balloons. Because I don't want to disrupt the proximal Esprit edge. So I'm going to leave the AT the way it is.
Yeah.
I'm not going to. He's a claudication. He's not CLI.
Yep.
I think we've done more than enough here. I'm going to pull my AT wire back, and I'm just going to do everything on the PT wire. Because I'm not going to get into this problem of dealing with a crushed Esprit.
I agree. I mean, we know the primary inflow, like me and David were talking about, is the PT peroneal. So we want to preserve the anatomy, what we started with. And we did a lot of hard work there. And we already have Esprit stents. So it might affect, again, like you said, we don't know what happens with the recrossing, but it might affect the patency or the structure of the scaffold itself. So I think it's better, like PK is talking about, keep the inflow towards the BT. There's no ulcer. We should be good. If we have to somewhere down the lane, we can.
So this is perfect. Go up now.
Yeah.
So there's a 4080, and we're going to do it on the PT wire. Keep going. Yeah. Go to normal. Yep. Perfect. It's perfectly landed. Notice how we stopped it right in front of the scaffold.
Beautiful.
All right. So now give me a 60, I guess 150.
Yeah.
So now we're just going to do this balloon angioplasty for a little bit, and then we'll do a 60 150. Let's talk a little bit about surveillance. I mean, one of the things, in our data, we've done a lot of Esprit, as you guys know. So far, it looks like, whole coverage is probably the way we need to go with this. Obviously, in this case, we have a lot of issues. We have inflow disease that we treated. and now we're doing DCB of the inflow disease with pretty reasonable outflow. So it's going to be, this guy really has to be surveyed closely, and then we'll take it from there. I mean, obviously we're using a DCB, which is excellent. God willing, there's no flow limiting dissection. If there is a flow limiting dissection, what are we going to do? Are we going to supera? I mean, what do you guys think?
Yeah. I think that's the next choice in this case, is if we have flow limiting dissection, which might, like you said, impair the patency of the vessels downstream, including the esprit, then we might put a focal spot stenting with the supera itself and hopefully make sure we have good results, both short-term and long-term for the patient. So
you got a 6 long DCB? Good. That's a great point. And how do you survey these guys? One of the challenges is looking at the esprit. Obviously, when you see them, it's very, very difficult. I think these are all questions we need to answer as we go forward with our experience in terms of how to survey.
So one way to see it is, so after putting the esprit, I've been tracking like a couple of patients. I think I did like 7, 8 of them. So I see turbulence in the stented area. I don't see it on the ultrasound, but I see a waveform change. I see I typically write it on the report so that I can track it on the ultrasound. So my technicians have been telling me, like, suddenly you see a lot of turbulence in that area. Mm-hmm. Yes, they put a power Doppler, not a color Doppler, but a power Doppler. When you put a power Doppler, you can see the change in the power Doppler, especially in the stented zone. So I've been trying to collect some data to see if we can.
Well, this is let's make sure we know where we're going to have geographic miss. So it's right around 5. So now give us the other balloon now.
I think unfortunately the echo guys and the echo technicians probably have to work a little bit harder, that they pull up. Ideally, in an ideal condition, they have to compare angiographic where really the esprit was deployed and try to hopefully scan it symmetrically on the vessel. It's a lot of work, like PK said. It's not easy because there'll be a difference between target lesion issues. I don't want to say failure, but TVF, TLR, whether it's the lesion that's becoming a problem or whether it's the vessel, because we exactly don't know where the Rayleigh stent started and ended. So it'll be hard to define it. But you're right, probably an extra work from the sonography standpoint where they have to compare the images, look at it while they're scanning.
Correct, 100%.
And then they define, because it's all about the anatomical assessment of the place.
Yeah. So perfect. So we're going to do a 6-0 here. And then the problem is, guys, Raghu Kaluri has done a fantastic job, just an absolutely incredible job in terms of characterizing this with ultrasound. So we actually are meeting with him and the Abbott team next week to talk about, with our ultrasound team, to talk about how do we identify these esprits and how do we go ahead and do it properly in order to follow these. When you're looking at TVR or target, or ISR or binary restenosis with these devices, it's hard in a regular everyday sense to be able to look at. So, anyway, we're doing this DCB now, and then we'll take some pictures, and then we'll decide how we're doing it. Now, remember, guys, we still haven't given up the through and through wire, as you can see. So we've been working really, really fast. And honestly, with our introduction and everything, it's just about an hour. Case is almost done. So, these complex lesions can be done really, really fast if you make good decisions. Part of that, I think, the good decision that myself and Karthik made sure that we got dual access, because I think in these cases that's quite difficult. It's important to get the dual access. So now you have the dual access, and you were able to cross, and you saw all the different techniques. We did CART, and then obviously did the twin pass, which really seemed to work. Okay, so now we're going to go, and we're on Angiomax, or bivalve Rudin, so we don't have to worry about ACT. So we've got, Damien is getting our superas ready in case we need it. I don't think we will, but you never know. You might have recoil at around 25. We know DCB failure is because of residual less than 30, so we're really going to look at that carefully and then decide what we need to do. We could put a 6-0 supera from 5 up to 25 and leave the rest with the DCB. We could, but we'll decide on how that looks. What do you think? We'll do a supera 6-0?
Yeah.
I don't think so.
Just from 5 to 25?
I don't know.
No? Because you're going to recoil. That's the problem.
Think so?
It's pretty tight where you went up around 25, and that area was very, very tight. So let's see. I mean, like Karthik said, we'll see. He's a claudic. And the last thing you want is all this work to go down. So we're almost at 2 minutes here. We're going to drop the DCB at 2 minutes and pull it out. Or maybe we should go to 3. What do you got? What's the IFU say? 2 or 3, Vishal?
3 minutes.
Oh, then let's go to 3 minutes.
Yeah. Yeah, but we'll see. Like I said, I mean, you could spot stent it if you have to, because PK is right. There's the chance. The only good thing is there's not significant calcification, so I'm hoping the DCB will work well to expand the vessel and thereby giving you good results. But the picture says 1,000 words, so we'll see what the angiogram says.
Yeah, exactly, right.
So yeah, I think we should be good now. 3 minutes.
Okay, down. Let it come down. And the other thing is also let the balloon come down because you still have some paclitaxel still on it. So let it infold and then we can just pull it out because we have the through and through wire. So okay, now we're going to do a quick DSA. Ready? Inject.
Wow, it looks gorgeous.
It's beautiful.
I don't think we need any spot stenting.
But the only worry is I think we should IVUS that osteum of that AT, make sure that plaque is not protruding into the vessel.
Let's take another picture down here.
Yeah, let's take one here. It looks like a little hematoma going on here. Inject.
Oh.
Where?
Wow.
No, I don't think so.
No hematoma.
No, looks great.
Looks beautiful.
Looks good.
We do the no touch technique. We do not touch the AT.
Let's do the IVUS.
Give a little bit of nitro, I think, take IVUS and we take
I want to do IVUS because I want to make sure that AT osteum, the plaque is not prolapsing into our posterior tibial scaffold. So, we'll do an IVUS right now. So as you can see, we use a tremendous amount of IVUS for every case. Really, all of us do quite a lot. The reason is for these kind of cases. I do want to shout out to Dr. Raman Sharma that he's enjoying his time with his family, hard-earned vacation. So I know he's doing well.
I was expecting for him to send me some pictures.
I know, nothing. He forgot about us, which exactly. I don't blame him. Actually, I don't blame him. All right, so here we go. This is into the scaffold. So show the scaffold. You can see the scaffold. Show the IVUS, please. Off, Laura. IVUS on, so you can see the scaffold. Just going to advance it into the scaffold there.
Yeah.
Right now I'm going to pull back. I just want to see the distal edge of the scaffold, guys, which is proximal edge. I'm sorry. Right up. Oh, that looks terrible. Look at that. Look at that goober. The goober uber. So that goober is terrible. Right there. So that's the plaque coming in from the AT. You see that? So the question is, do we just scaffold with a 375, post dilated to the 4, and just jail out the AT? That's what I'm going to do. Give me a 375 short scaffold, guys. Yeah, 375, 28 of scaffold. Because I think it's too important right now to lose this scaffold. We've got fantastic flow. And I think, again, I want you to, let's do just an angiogram for them. I want you to see the difference, how good IVUS is in showing you this. So here's the angiogram, which shows fantastic flow. But you see that little haziness? You got to cover that. So what I'm going to do is I'm going to go ahead and balloon this, and I'm going to put a scaffold in to that, and then I'm going to balloon it, post-dilate it to a 4. I can take it up to a 425. So according to my IVUS, which is up to, according to my IVUS, my posterior tibial is only a 441. So I'm okay with going with the scaffold at this level, which is going to now preserve my runoff into the thing. And I know my AT is there, but we can always preserve it and get it back. So here's a third scaffold. This one's going in the popliteal. So this is a popliteal scaffold. Yeah. 375, 28 is fine. We can even go 38, but 28 is fine.
28 is good.
You want to go 38? Let's just go big.
Yeah, I know, exactly.
38. Give me a 38. Price. 38. 375, 38.
Yeah. I think it's a very good point that PK brought up, is trying to make sure we cover the lesion as we do in this case. And because, like I said, it's a scaffold and he's still in the claudication phase, hopefully he's not going to progress to a point where he develops an ulcer in the AT territory. So after 3 years, when the scaffold is gone, if you have to intervene on the AT, it's as de novo as it can get. So you can try work on it at that time. So I think it is a very good observation. IVUS helped us right here to give us more information and then make an educated decision.
I'm going to throw a wrench in the plans here.
Oh, my Lord.
So now I may not use the scaffold because I just remembered we used paclitaxel. Now we're using sirolimus. So is that smart? Dumb?
That's okay.
Pop. Talk to me.
2 drugs is good.
No, I mean,
Two different drugs is good. So
once,
one of them
once
is
the
going to work.
Limus comes in, no, listen, I mean, once the Limus technology comes in, of course, we want to do it the same way. I don't think there's a direct interaction.
All I know is one of them is going to work. So
Well, I will give you an idea, right? We never did it acutely in the coronaries, but I'm old enough to have done Cypher and Taxus in the paclitaxel in the coronaries. So therefore, if we want, we can walk over and ask Dr. Sharma what he thinks. Mag it up, guys, and see what his thoughts are, because obviously he has a lot of experience in this. So I'm just going to go ahead. Their markers are marked together. So now we're going to go up. There you go. 2. 5 seconds. 5 seconds. Okay, leave it up. 30 seconds now. Now give us a 4 or 4. Give me a 4-0 post-still balloon.
4060.
Dame. Okay.
Yeah.
Okay. So remember that these balloons can go to 425.
Correct.
If you need
up.
to, but you 0.5 up. But I sometimes I wanted to sometimes use a 5 just to give Abbott a little bit of agita. But you have to figure that out here. Coronary's fine, Damien. Coronary's fine.
Yeah. Take a 4-5 or a 5 coronary. Yes.
I would go in
Oh my God. We're gonna go in and do the overlap.
Yeah, overlap.
And then we're gonna IVUS to make sure it's opposed. Okay, go up here.
Good. Great. Well expanded scaffold. Balloon looks good.
So we're gonna IVUS after the 4-0.
Yeah,
balloon.
post-still.
Okay. All right, let's just do a picture while they get this stuff together. Inject. I'm pretty sure we're probably gonna lose the AT. Oh no, it's still there. Okay, actually, it looks better. Looks better.
Yeah.
All right, now we're gonna do a 4-5 here. No, we'll do the 4-5 balloon first. 4-5, please.
Yeah.
I mean 4-0. Sorry. Okay. So we are going this in this level.
Nice. Again,
And I do want to tell everybody that there is no data regarding, if you've DCB'd and now you're using a scaffold. This is clearly not something that we recommend. But in this case, with all the work we've done,
options.
I don't want to. Yeah, I don't think I really have an option.
Correct.
So para is not a good size there. Regular bare metal stenting is not a good size there. So this is probably the right thing to do. So that's why we're doing it. I just want to be very clear. We're not advocating it for anybody.
Yeah.
So we're doing the overlap.
I think it's a good clinical decision to do it the way it is to get great results. So definitely recommend it. All right, good. So this is a 4-5 balloon?
No, 4-0.
4-0 balloon. Okay, apologies. Perfect. Good.
Okay.
All right.
And now
Pull back a little
more. Okay, Karthik wants a little more proximal.
Easy.
Right there. Okay, done. Good. Now we're going to do an IVUS.
Wait.
Okay.
All right.
Then an
Hopefully
IVUS.
there'll be our final pictures.
Yep. And then we'll do the runs, and then we'll be hopefully done. Now we just have to. I do want to IVUS the proximal to see if there's significant recoil in the SFA. So we'll take a look at that.
Yeah.
Again, it's still just an hour. We're an hour and 5 minutes so far. It's not so bad. Shalini, talks very slowly, so she took 15 minutes for the presentation. So, you know how it is. All right, good. Look at the IVUS flying through.
Just
Ready?
trying to do a
Record.
gap filler technique. Start.
Record. Look at that. Wow. Wonderfully expanded.
Very nice.
All right, I'm coming. There it is. Now I'm in the second scaffold. Look at that. Well abutted, right? No gap.
Yeah, no gap, no malapposition.
No gap,
Looks
no
great.
malapposition. Now we're out. Now I'm going to do this part here. This plaque. We know this plaque. I mean, I'm not going to stent the whole. Look at that. See, this is the stuff that scares me, guys. Look at this.
So the issue, I guess, not. I wouldn't say an issue, but
The
one of
whole
the
thing is gonna
findings
look
that
like that.
So remember,
The whole
it's
thing is
balloon
gonna look like
angioplasty. The whole thing is going to look like
It's
that.
PTA. I mean, the
So
whole thing is.
Karthik is saying don't IVIS.
No. Yeah, exactly. I was going to say.
What I believe is, I have done
No,
this,
it's good.
right?
It's
I
good.
do it all the time. And then when I bring them back after like 3
They
months.
look good, yeah.
They look great.
Yeah.
The vessel completely
Yeah,
remodels
yeah.
itself. DCB just remodels the whole vessel.
All right, ready? Let's do let's do a picture here.
I think sometimes IVIS can scare you, but I think you should not be scared because
As
you'll
long
learn
as
this
it's
shit
not
about.
flow limiting, I think it's totally fine to leave them. I mean, it's
Look at that.
dissected, yes, I understand.
But that's what PTA does. Yeah.
Give me a little nitro, Ray. Give a little nitro here, guys.
Yeah,
Fluids.
I just gave
Back
nitrobenapamil for itself before you
Yeah,
did
just
that.
give a little bit. Give 200 here. Flush it, guys, when I ask you to. Flush.
That's good. Fill up a little bit. Good. That's good.
All right, DSI.
Ready? Right. Inject. It's great.
Beautiful.
Yeah, I mean, there's dissection,
Much
but it's
better.
not flow
Come down.
limiting.
Yeah.
Going to do
I think the results are very good. I mean, you can see the AT is still there, the PT peroneal getting the good blood flow all the way down. I think this is the best result you could ask for. Yeah.
No contrast.
I got it.
Oh, yeah.
Don't worry, we'll just do the last 2 pictures here.
Oh, somebody is giving the special effect where the camera is swinging in the air. Good. All right.
Cindy.
Now let it fill.
Beautiful.
Look at that.
Okay, foot shot now. And now. One more. We have enough for one
I have
more?
it. Yeah.
Cindy?
It's a beautiful result.
Amazing.
Very good.
Very good. Okay, guys, so we're done. Now, just last comment on surveillance, antiplatelet therapy, so on and so forth. You're going to want to let go of that. I'll pull this wire back.
So aspirin, well, in this case, I mean, I don't remember if the patient was on Xarelto, but usually we'll do antiplatelet therapy of aspirin, Plavix. I mean, with scaffolds, his recommendation is 1 year, just to remember that.
Just to make sure.
So it's not like usual 1, 3, or 6 months based on a peripheral intervention. The recommendation is 1 year with the scaffold. So that's one thing you have to consider. And obviously try to see, I would probably put the patient on Xarelto 2.5 if there's no high-risk bleeding issues whatsoever. But David, any comments?
No, I completely agree. I think it's very important to really remember that it's 1 year for this spree and not the normal 3 months.
3 months.
Because we have encountered that, early on. But that's a very great point to make.
Okay, we have a little dissection proximity. We're going to leave that. It doesn't look flow limiting.
No, I think it's good.
The idea is we're going to be chasing it, and so I think without any significant recoil, and the DCB data this was not studied, but clearly did not show that this was significant. But we'll follow him. So with that, we're signing off, Vishal. Thank you, Karthik. Thank you, team, for everything. And we're going to use a per close here and close it up. See you guys next month.
Yeah. Thank you so much, everyone, for joining us here from Mount Sinai in New York City. Another great case of endovascular intervention techniques, tips, tricks, algorithms, devices, and other stuff. Hopefully, it was helpful to you. Any questions, concerns, you can email us. You can go to our website, ccclivecases.org. Under the peripheral tab, you can leave comments. You can see our cases, archived cases from previous, our live cases done previously in the years, and any comments you can email us. Otherwise, we're going to see you next month, March 26th, Wednesday, 8 o'clock Eastern Standard Time. Till then, have a great day and the rest of the year, month.